Good morning, good afternoon, good evening, depending on where you're joining us from around the world. Welcome to the Global Foot and Ankle Town Hall. 24 hours, we're going to go straight. This is brought to you by the Perec Family Foundation. The foundation was set up back in the 2000s, mid-2000s, with really the goal of trying to leave this world a little bit better than where we found it. And so our initiatives first began in India with foot camps that included not only charitable surgeries and charitable clinics, but also an educational platform so that we could teach healthcare providers, surgeons, how to do some of these esoteric foot and ankle cases. My parents were immigrants to this country, and really they lived the immigrant dream of hard work, dedication, and finding a better future for themselves. But we always looked for ways to give back. And in the beginning, we really found a lot of support through 3 foot and ankle surgeons in India who helped us pioneer a lot of what we did initially in India. It then started to include physical therapy educational sessions because my wife is a physical therapist, and we had an interest in trying to elevate the foot and ankle care, not only from an orthopedic perspective, but also from a physical therapy perspective. So the foundation went throughout India and in fact reached out to other countries around the world as we continued to grow. But as we all know, COVID hit us all hard globally, and that made camps come to a standstill. And so with that, we saw an opportunity to bring a virtual platform to really train and teach over a 24-hour period of time. And 2021 was our first time doing this 24-hour global town hall, and it has grown every year since then. And we expect over the course of the next 24 hours to have between 3,000 and 4,000 individuals from around the world tuning in. Our goals during this 24-hour period is to review the basics in foot and ankle post-traumatic arthritis, but also inflammatory arthritis, learn from faculty mistakes through cases that are going to be shared and discussed. We want our attendees to really be interactive. You have the chat box. Feel free to ask questions as you go through and listen to the content over the next 24 hours. Our 24-hour meeting and all of our efforts in the foundation are not possible without industry support. So I want to thank all of our sponsors making this conference possible, this 24-hour course possible. In addition, we've got to thank our over 90 faculty members from around the world who are going to be joining over the next 24 hours, providing a lot of the insights that they have learned through the years of taking care of patients. And without further ado, I'm going to open this up and turn this over to a good friend of mine, Scott Ellis. This next hour is sponsored by Restore 3D, and so we want to thank them for their efforts today. Scott, it's all yours.
Celine, thank you. I feel so fortunate to be part of the first group for this 24 hours and have a wonderful set of colleagues that are going to give talks in this session. And I wish you luck for the entire 24 hours. And thank you to the sponsors as well. So we'll start the session. And again, I would love for everybody to be interactive as well. As Celine just said, I'll be checking the chat constantly. We may answer some of the questions by text through the chat, but I'd also like to bring some of them up to the panelists in between each session. So let me get going so we have time and can ask questions. So the title of our session, the next hour, is The Evolutionary Tale of Ankle Implants. Celine came up with the idea. I wanted to change it just a little bit to topics I thought that would achieve the same goal. But I think long story short, we've come a long way with total ankle replacement. It's going to vary some from country to country, but we've learned a lot. Through the next hour, I hope to teach everybody through our speakers kind of what have the changes in designs been, how we have improved in our surgical technique and instrumentation, and then some on how we can manage complications. I'll introduce each speaker as we go. So the first will be Casey Humbred, who's going to talk to us about the evolution of the design. I know Casey quite well from being on the board with her for the Foot and Ankle Society. She's now the head of Foot and Ankle at Penn. I remembered all this, Casey, but looked it up too. So it was at Mount Sinai School of Medicine, Hopkins residency, Mercy Fellowship, was at Hopkins for a while as an attending, and now, of course, is at Penn. So, Casey, get us started. First speaker for 24 hours.
Thank you so much. I'm hoping everyone is seeing my screen, Scott. Say no if that's not the case.
Yep, I could see it.
Perfect. All right. Well, really excited and honored that I get to kick us off, and we'll go to the very beginning, from hinge to harmony. So early designs. When we say early, we mean early. The earliest idea for ankle replacement was introduced by Gluck in 1890, where conceptually he threw out this concept of replacing the ankle. And the first version of an ankle replacement was done by Townley. These are radiographs of that. It was a talar hemiarthroplasty, and this was performed in 1963. Although that feels long ago, when you think about how much we've come, it's really not that long in the history of medicine. Resection arthroplasty was proposed in 1967. And then we hit the age of arthroplasty really in the 1960s. And this, of course, is Dr. Sir John Charnley. Of course, he practiced in England, so he would go by Mr., as is the tradition for surgeons in England. And total joint arthroplasty is generally considered one of the top 10 greatest medical achievements of the 20th century. The best papers ever written, in my opinion, was published in the 80s, where it said that total hip arthroplasty had a relative quality-adjusted life year benefit greater than coronary artery bypass grafting when you look at the impact on patients' lives. And we certainly get to see that as orthopedic surgeons. So what's good for the hip is good for the ankle, perhaps? Maybe not. So ankles were slower. These are the list of first generation total ankle implants in the 70s and early 80s. And I really appreciate this as someone who is blessed to have an orthopedic surgeon as a father, who, when I told him that we were doing total ankles when I was a resident in the 2000s, he said, well, that's a dreadful idea from what I remember from the 80s. And these first generation implants, and there were a lot of them, in general, did not do well. Here's some pictures of these first generation implants. And you can see that in general, they had a polyethylene cap, and then the talus was contoured. So these failed, and they failed pretty abysmally. And the main reason, as the topic of the talk says, from hinge to harmony, it incorrectly treated the ankle as a hinge joint. These had a really tiny prosthesis to bone interface, and there was excessive bone resection because they were cemented with a big cement mantle. So then you weren't into the strong area of the tibia or the talus, and this created a huge stress transfer. They were also highly constrained, which even worsened the transfer forces as well as the rotatory forces. So there was poor fixation, poor stability, leading to loosening and subsidence. And then alternatively, there was the other extreme of highly unconstrained implants, but those were completely unstable with bony impingement and had a lot of pain. And this is from people, father, who came of age during this initial generation. These are some quotes. This is from the British JBJS from November of '85. In view of the high complication rate and the generally poor long-term clinical results, we recommend arthrodesis as the treatment of choice for the painful stiff arthritic ankle, regardless of the underlying pathologic process. Another one, clearly the answer to the question of replacing the ankle joint using current techniques must be no. So then we move on to the second generation. So in the first generation, there was cement for fixation, there was an all poly tibial component, and then the metal talus. What happened with the second generation? Well, the second generation moved to a different concept. So no longer cementing plastic into the tibia, instead having a metal prosthesis. And there were two designs that came out, mobile bearing versus fixed bearing. In diagram A, you see the two component, which is the fixed bearing, where the polyethylene seats directly onto the metal. And then there's a talus component. In contrast, there's a 3-component prosthesis with a mobile polyethylene. And this mobile component articulated with both the tibia and the talus. Importantly, these implants started to understand how the ankle joint is not a hinge. And this is from a classic paper from the Orthopedic Clinics of North America by Semarco, describing and showing the multiple instant centers of rotation that occur throughout the ankle joint. It's important to always understand that the ankle is not a hinge, it both rolls and slides. So, and you can compare these and think about diagram A was that first generation. Then you can see how we're starting to shift, moving into the second generation. These were the primary second generation implants, the buccal pappus, which is all the way over on the left, the star, which is in the middle, and then the agility. These implants were semi-constrained. They weren't cemented, even though some of them were approved only with cement through the FDA, but they had this porous coating to allow bony ingrowth. Importantly, there was less bone resection used for these total ankle implants, as well as being less constrained. But amidst that decreased constraint, there was an increase in implant surface area. There also was improvement in cutting jigs, which, as we know from the experience, especially with total knees, cutting jigs and making sure that you're having accurate cuts really defines a lot of reproducibility of good outcomes for total joints. And there was also focus on not resecting as much bone and decreasing that load transfer to the prosthesis. So where did we go from there to now? So how we think about third and arguably fourth generation total ankle implants that we're using now. And there's a few things that define it. The ligaments are really important for stability so that the implant itself is not acceptable for stability. You have to balance it. And this is really also building on what we know from other total joint replacements. Anatomic balancing as part of our alignment, making sure that you're in neutral and trying to limit bone resection. And this is taken from an update on third generation implants published in JAOS. So these do not require cement, minimal bone resection to try and make sure that both you don't weaken the bone and there's an opportunity for good ingrowth, and trying to really have high contact areas. This is a list, and I apologize if it's not exhaustive. I tried to hit all of the big names. So these are some of the common systems currently in use in the United States. I'm just going to go through and show some pictures because I think it's really important to look, and you can start to then see how there's a lot of similarities amidst these implants. So this is the cadence, and you can see that anatomic talus with the polyethylene component. The inbone, this is an implant that is frequently used for many folks, use it as a primary, but also used as a revision because it's a large stemmed implant. This is the infinity implant. This is the salto implant. Again, you're seeing that anatomic talus. This is the star. This is the only of the second generation implants to have been continued into third and fourth generation designs. The trabecular metal. This implant is unique, and that is approached with a transfibular technique. But again, you're seeing an anatomic design here, particularly of the talus and the tibia matching it. This is the Vantage total ankle. This is the Apex 3D ankle, again, an anatomic design. You can see here how there's a goal of minimal resection of bone, big contact areas, and a very similar thing then seen in the Kinos axiom. One of the big debates that continues, and I don't think we'll settle tonight, is about mobile versus fixed bearing. So in the mobile bearing, the polyethylene is not fixed, so it's a 3-component design. There's some advantages to this. It minimizes constraint and it optimizes the ability to conform, but the disadvantage is it is susceptible to edge loading as well as impingement from subluxation. In contrast, the fixed bearing total ankle, this is where the poly is fixed to the tibial component. So it's technically a 2-component design, even though when you put it in, it is 3 pieces. Since the poly locks into the tibia, it's considered a 2-component design. This eliminates the risk of subluxation, but it is prone to eccentric loading and potentially poly wear. I think one of the biggest things that defines our current implants is patient-specific instrumentation, and this was taken from one of my cases. And the really wonderful thing when this is available is that you have 3D printed anatomic cutting guides, which both decrease your surgical time and also minimizes the learning curve, as you can have multiple checks with your preoperative plan to make sure that what you're doing in the operating room is matching it. This leads to improved outcomes, and it also really helps with joint alignment. Obviously, I recognize this technology may not be available everywhere, but it is the hot topic and where we're going to get to a place of harmony in total ankle replacement. I'm going to pause there and hand it off to Dr. Ellis.
Thank you, Casey. It's amazing to see the long list of implants, right, that are currently available. And I remember myself when we were first starting, I had this idea that I would try to learn them all, but it gets to the point pretty quickly that that you just can't do that. And well, at least for I can't, because you just don't have time to become an expert on all of them. Do you have certain implants that you've used, or have you evolved using different ones over time? And do you, when new implants come out, what's your approach to taking on that technology?
So I started doing the implant that I had learned during fellowship. And I think that was really common for a lot of us, that I had trained somewhere and we'd done a lot of one type. And then I actually went to some courses and explored a bunch of different total ankles. My chair at the time had done a different type of total ankle. And that was a big interest of saying, do I like this one? And then ultimately, after several labs, I just got really comfortable with it. And this is just what I'm comfortable with. It's not an argument for or against it, but I got really comfortable with the Infinity. And I also think sometimes it's influenced by the fact that I have a phenomenal rep who had done a lot and was able to get me resources for training. So that's what I'm currently using, but I'm incredibly open to anything that's going to lead to improved outcomes to my patients. So I wouldn't say I have a dogma about approach. For me, it's really if I can get it to look like my preoperative plan, that's always the goal. And always trying to keep up with the literature and see if anyone's going to be able to beat results. Though I will say, I think that most total joints, because we're getting better with our registries and our data tracking, are a little bit going to be like car seats. There's no point in buying a super expensive car seat for your kids, because as soon as an innovation comes along that makes it much safer, everybody gets it, and it's often required. So I'm hopeful that we're there with our medical implant design, that if someone comes up with something really brilliant that changes how our patients do, I think everyone's pretty quick to adopt it. Just like everyone's pretty quick to get rid of things that don't do well, like radiated polyethylene.
Yep, I agree. It's nice to also get good at one that you can reproduce, right? But I think we all have to just watch this evolution too and stay ahead of the curve. Okay, great job. So let me introduce our next speaker. So Rishan Kadakia, Dr. Kadakia is going to talk to us about some of the instrumentation. I have a feeling, improvements and evolution of instrumentation. I have a feeling that some of those things that Casey was talking about, you're going to be talking about a little bit more depth here too. So Rishan, while I talk, just get your slides up or share your screen if you don't mind. But he was at Vanderbilt undergrad, Vanderbilt Medical School, Emory residency, Duke Fellowship, and now is back at Emory. So thanks for giving us a talk today. And again, please share in the chat here questions that you might have.
Thanks, Scott, and thanks for having me. Thanks to Dr. Crack and the foundation for putting this together and organizing all this for us. So I'll talk a little bit about instrumentation and technology and how that has advanced. These are some of my disclosures, but as we heard, ankle replacements have come a long way to where we are today. And as these implants have evolved to what they are now, the instrumentation has also picked up, that we'll discuss a little bit. Ankle replacements, as all of us know that do some of these, are quite technically challenging. There's a lot of aspects of this that make this tough. These patients often have had trauma in the past. They have multiple incisions. Their soft tissue envelope is less than ideal. Most of the time they have some type of deformity you have to manage. Comparing hips and knees, this is a smaller joint, so there's the technical challenges of that, and then the instrumentation has to match that as well. And, as Casey touched on, there's all kinds of planes of motion here that you have to consider when you're, looking at ankle replacements as well. So most of the implants, all for one, are put in from the front. So a direct anterior approach, most commonly the interval between the tib-an and the EHL. As all of us know that do these, wound healing is the biggest factor that makes this a challenge initially. The reported rates of wound issues go anywhere from 10 to 30%, depending on the study you look at and the complications. You can have anything from delayed wound healing that you treat with some wound care and antibiotics to frank dehiscence that can be quite devastating for the patient. So a lot of initial advancements made as this started to become more and more frequent was on how can we modify our surgical approach to help prevent this. And so there's a couple of things I'll talk about. One is this kind of extensile anterior medial incision that has come about. The premise behind this is taking into consideration the angiosomes around the ankle. So the thought is with the direct anterior approach that you violate that central angiosome. And the idea is that leads to kind of skin necrosis and death, particularly at the central medial area of your incision, which is where we commonly see problems. So here, by extending your incision, kind of doing this, extending it medially, you avoid having to cut in that area and violate that angiosome. And I've seen some good success with this in certain cases. Our colleagues in Japan actually have created this modified anterior lateral approach, in certain cases where they feel like the anterior soft tissue envelope may not be the best. And the idea here is you use an anterior lateral approach, but instead of going through the, lateral to all of your extensor tendons, you kind of come in between the EDL and EHL tendon here. So they've reported good outcomes on this with less wound complications. And again, in 2013, the trabecular metal implant came out that we saw on the previous slide. And this is placed through a lateral transfibular approach. It's very unique in the sense that using this approach, you can actually put in an implant for the tibia that is more anatomic, which, is obviously important for motion. I don't have a lot of experience with this particular implant. Would be great to hear at some point from the panel if they do, but I have a partner that does this and she feels like it does pretty well. And looking at the literature with regards to this, there's plenty of studies that show good survivorship, at 5 years out, and low wound complications as well. So thinking about instrumentation now and how that's changed, there's a lot of things that this instrumentation has to do for us when we're doing ankle replacements. We have to be able to make the cuts in the right coronal plane. You have to consider the rotation at the sagittal plane and resection height, component sizing. So the instrumentation here has to do quite a bit. And like we talked earlier, it has to be quite small. So looking at how instrumentation has been for a while, I'm sure most of us who do ankle replacements have seen some type of extramedullary jig here. And these are 3 separate total ankle systems, but you can see the similarity between them. They're secured to the proximal tibia, either with some kind of strap or a pin in the tibial tubercle. And then there's an extension that has another jig down at the ankle joint. And through various mechanisms, you can then use this to set your resection height. You'll use your tibia to set your alignment and so on and so forth. So a lot of similarities between the systems, even the earlier generation systems with regards to how this was done. There is a little variation with the in-bone. This came out, the in-bone came out in 2005, was bought by Wright in 2008, but they actually use an intramedullary referencing system, largely because of the implant design that puts stems into the tibia. So thinking about how that works, ankle arthritis really isn't symmetric. In addition to the coronal rotational deformity you see, a lot of these patients have post-traumatic problems. So, they'll have like a tibial shaft or some, a syndesmotic injury. And then, how do you set your alignment? How do you figure out what your coronal plane alignment is going to be when the mechanical axis of the tibia is off the anatomic axis? And then how do you take into consideration proximal deformity at the knee? What about the foot? And then all of this you got to think about and eventually have to somehow figure out soft tissue balancing as well. So looking at a jig like that and trying to figure out how to do this is tough. And where, we touched on a little bit is a case like this where you have, an elderly gentleman who has significant, ankle arthritis and valgus, but there's more to it here. He's got cavus, there's a rotational deformity to this. He's got wear of his anterior plafond. There's ossification in the lateral soft tissue to indicate that he's had, his lateral ligaments are probably not great. So there's probably some soft tissue work to do here. So, using traditional instrumentation for a case like this it's tough. There's a lot of things to think about, a lot of moving parts, and the instrumentation is pretty small and finicky at times. And so this is where patient-specific instrumentation has really helped. This was introduced to the U.S. market around in the 2012. One of the first systems was the Wright Prophecy In-Bone, and then the Wright Prophecy Infinity. There's many more systems out there today, and the idea here is you use a patient CT scan, and using that you can create custom patient-specific instrumentation, to guide proper implant alignment and placement. And I'll show some examples here. This is a case, the case that I showed, and using their CT scan, you can kind of plan out your cuts, your varus valgus, your slope, your rotation, even implant positioning, using kind of their CT scan to plan all this out. And then you can design these custom 3D printed guides, and these sit on the tibia and talus in one specific location, are pinned in place, and then you can slide the cut guide over it. This is just an example of how you can take a very challenging case and using patient-specific instrumentation, their CT scan, get a better understanding and plan for how to do a case like this, which otherwise might be really difficult using standard instrumentation. There's been a lot of advancements since then. The case I showed, you had to pin the alignment guide, take that off, then put a cut block. A lot of the newer 3D printed patient-specific cut guides have cut-through options. So instead of having a guide that you put on and take off, you kind of skip that, and the entire cut guide itself is 3D printed. There's been advancements to make this a little more reliable. Paragon's cut guide has a medially based extension that tries to find a more consistent way for you to place this, which, a lot of us who do patient-specific stuff sometimes say that, hey, should only fit in one spot, but sometimes it can be a little tricky based on their anatomy. And this is an area of ankle replacements that's evolving. There's a lot of changes that have come to systems that have been there, and each system is starting to develop their own patient-specific instrumentation. So this is an area that continues to evolve. Thinking about patient-specific instrumentation, I think you got to ask it with any advancement, do you really need this? Thinking about some of the negatives or downsides, there is a cost to the patient. Obviously, there's a cost to the CT scan you have to get. And, most of us get CT scans, but, sometimes people don't. It's surgeon preference. And obviously, there's the cost of that, the radiation of the patient, but also the cost of printing these. Printing the guides themselves range anywhere from $1,000 to $1,200, depending upon the contract you have that your hospital has with the company. And then there's the time to print, which can take anywhere from 4 to 6 weeks as well. And the other thing that I don't think a lot of people think about is the lack of experience that you then have with standard instrumentation. If you solely rely on patient-specific instrumentation, I do think that it's problematic, especially when you're training residents or fellows, because you do need to know how to do it with the standard instrumentation. If, for example, the cut guide doesn't fit, or, if somebody drops the cut guide, which unfortunately has happened before. So thinking about this, is there literature to support this? And there's a lot of data and studies that have come out recently, as this has really been a hot topic in ankle replacement. So this is a very recently published study, is retrospective, multi-center, looked at kind of the accuracy and reliability of a PSI, or patient-specific instrumentation. They had 80 cases, and they showed that it was accurate and reliable with regards to positioning and alignment. They did note that for most cases, the tibial size was correct. And, again, most cases for the talus too, but it was clearly a little lower. Another study, this was retrospective, a single center that tried to, that looked to compare patient-specific instrumentation with standard instrumentation. They had about 100 cases. They really showed that there was really no difference with regards to alignment between patient-specific instrumentation or standard. However, they did note that there was less operative time and also less fluoroscopy use, which are two very important factors in my mind. So, and again, a common theme here is that the sizing wasn't perfect. With the tibia, it's a little more accurate, but however, in their study, the talus, half the times they had to change the size. And interestingly, this is a study that looked at the cost, time and cost savings. This was retrospective, single center, again, compared patient-specific with standard. Again, they noted that there's more OR time, tourniquet time, and fluoroscopy time with standard instrumentation. And when they looked at a variety of cost analyses, it really depended on what methodology you used. But however, overall, PSI did have better cost savings when you looked at the standard OR cost utilization. So a lot of benefits to patient-specific instrumentation that we're seeing with ankle replacement. So the literature does demonstrate that there's less OR time, less fluoroscopy time. It's as accurate and as reliable as standard instrumentation, and there may be some cost benefits, especially as the cost of 3D printing goes down, and the cost of printing these and the time to print these goes down. All of this will only become more efficient. It's not great at predicting size, particularly with the talus. I've seen this in practice. I would love to hear what the panelists think about that as well. This is continuing to evolve. A lot of these companies that have patient-specific instrumentation are now coming out with programs to help surgeons plan for any osteotomies or soft tissue rebalancing that has to be done as well. And again, I think it's very important, if you're going to do patient-specific instrumentation, you should be familiar with standard instrumentation as well. So, looking at instrumentation in general, as the implants get better, as we learn more about ankle replacements, what works, what doesn't, the instrumentation advancements will follow. All of these advancements in techniques and surgical approaches will improve outcomes. Again, patient-specific cut guides and patient-specific instrumentation is the hot topic right now, but there's a lot of things on the horizon. A lot of things that have come out in hip and knee arthroplasty are making their way to ankle replacements. So, navigation, and then augmented reality, and how that can help in surgery too. So, again, I just want to thank you guys for having me.
Richard, thank you. You said a lot of things I actually probably would notice in my own practice, just never had a chance to put a talk together about it or say it. One of them is, and by the way, everybody, please feel free to ask questions in the chat. We're happy to answer it. And it's seamless from the beginning. We'd like you to learn how this be interactive. But one of the things I've always said, Richard, too, is and I tell my residents and fellows, you should learn the standard instrumentation before the patient specific, just like you did. The thing is, once I started using patient specific, I don't think in the last 2 or 3 years, I don't think I've ever gone back. I always think about dropping that thing on the floor, like you said, and thank God, knock on wood, it hasn't happened, but I don't go back. So do we really need to have the standard instrumentation? Is that ever just going to go away?
So I try to make it a point at least once a month, every time we rotate a fellow, that I'll do standard instrumentation. I know it's a pain when you do like an in-bone to have to pull out the frame, but I try to make it a point, because I've had cases where it either just doesn't fit, or, I mean, it happened to me not too long ago where one of the cut guides fell, and I think we have to just be careful to rely on patient-specific instrumentation too much. I mean, I think it certainly helps, and I do it for nearly all my ankle replacements. But I will force myself sometimes to use standard instrumentation just to make sure I can still do it, that I can teach it to the fellows. But I don't know. That's my thoughts on it.
Yeah, and I agree with you too. I guess the more I do the PSI, the less likely I want to abort, because I feel so much more comfortable with it too. But maybe you need to just force yourself. I mean, likewise, I've always wondered for the in bone for that jig, that takes a lot of work to put that together. People who've used it for years love it, and they know all the nuances of it. But as I've done PSI for that, I just don't use the jig anymore. So the question is the jig something that will disappear?
Yeah, I mean, I think as instrumentation improves, the need for it will be less. But until that changes, I think it's important to know how to do it both ways. But no, I agree. I think it becomes challenging to go back and have to do it the other way.
One other comment and then question, and then Josh, you can start getting your talk up there too. So I saw what you said about, and literature shows about how we, I guess somebody's saying it goes blank with no volume. Can you guys hear me?
Yeah, we can hear you.
No problem. Okay. The changes in the tibia versus talus, I've noticed that I tend to downsize the talus compared to the plan, because I feel like it has advantages, including less gutter debridement, maybe less stiffness. The tibia, I almost always go with what the plan says. So I don't know, is that your experience? You change it a lot, or are there specific reasons why?
For me, I agree. Same thing. I usually end up downsizing the talus, but the tibia, I've never had to change the size of the tibia, but the talus, I've almost always downsized for similar reasons.
Yeah. Annie, thank you. Question. Okay. So, and you can answer this, Richard, or the others. Do you routinely have standard instrumentation available in the OR as a backup?
Yeah.
And
anytime I do, always have them bring it in.
Yeah, I guess I do too, Andy. Although the big one is to decide is for the jig. And if there's a reason I'm using the in bone for it's not deformity, I don't even have them put the jig together. So in that sense, I don't. Rishan asks, and Casey and Josh, maybe you, what's your experience or thoughts on the lateral approach, total ankle? Any thoughts?
I don't have experience with it. I definitely understand the appeal, as Lou Schoen's one of my mentors, and certainly avoiding the challenges of the angiosomes from a direct anterior approach. But it isn't something that I have experience with. I think of the limited literature that we have, it does seem that it's equivalent. And I have a partner who really loves it and feels that that they really like the minimal resection, and they're incredibly comfortable with doing deformity correction with it. So I think, like probably every total joint, when you get really good with something, it becomes reproducible.
I trained on the Zimmer ankle in Iowa in fellowship for the year I was there. So that was my limited experience over 10 years ago. But I thought it was pretty cool, but it wasn't something I carried over to my practice.
Yeah. Okay. So thank you, Rich, and great job. Okay. So I'm going to turn it over to Josh now. As we get better with instrumentation and our implants, and as we do more and more of these, we're going to have more complications, and our ability to manage these complications has to evolve as well. So I've asked Josh to talk about how that has evolved. Josh you can see he's at UNC. You've been there for a while, except for, like you said, the fellowship. So he was at UNC for medical school and residency, Iowa for fellowship, and back as a foot and ankle surgeon in Chapel Hill. So thanks for being here. I look forward to your talk.
Thanks, Scott. Thanks, Elon, for having me here to give this talk. So managing complications in toe ankle arthroplasty. So we've talked about these designs, and I won't go into these, but certainly there were more more complications early on with the non-anatomic design, more bone texture reliance on cement, and the salvage options were limited. Most frequently fusion, and in the bad cases, amputation. So as we think about this list of complications that I'll go through, and I'll review some literature as I go as well, I think the goal is obviously to number one, to avoid these things to them, and ultimately not to, when you're approaching these things, that you don't feel like North Carolinians in 2 inches of snow. And that's a real car fire 10 years ago. But this is a case I was able to actually meet with a friend. Sometimes when it's good to be able to meet with a friend to talk about things. Diorio helped me out with some cases here. So this is a case of his he shared with me. This is a patient with a total ankle. He admitted that he did not check vascular flow before the surgery, and a thin lady, and she developed this eschar. It was debrided back at her home. They removed the tibialis anterior, and he had to have his colleague do a radial forearm flap, and apparently this lady did fine. So when you think about wound healing issues, and Rishan just touched on this a little bit with the approach, but certainly one thing that we can do to prevent wound complications that's been studied in addition to the approaches. This is a study from Duke that looked at that. That was what was associated. Wound complications were associated with longer operative time, and these aren't always wound complications, or they need a little antibiotics. These can involve things as serious as loading amputations, which is important to talk with our patients when we're discussing risks. And this also has a financial implication. You know, the average wound complication from a group of patients at Duke had a mean increase of $186, which seems low, but I'm sure that included even those oral antibiotic patients, but also the free flap patients as well. There are things that we can do that are shown in the literature to help manage our wound besides the approach. Things as simple as a compressive wrap that Dr. Haddad studied in 2015. Dr. Perek looked at this wound closure assistive device placed around the incision. And there's also, this was a paper from last year on the far right, with these elastic type strips that relieve tension over the wound. Moving on to the kind of malleolar fractures. I think these at one point or another, if we've done enough total ankles. The tips with this, guarding with a K-wire is a good technique. I routinely do that when I'm doing a total ankle, even if I'm not particularly worried about it. It's a simple thing to do. Gets you good pressure doing a medial malleolar fracture well, in an ankle fracture without a total ankle. You have to beware of the medial malleolus and a pull. Think about the offloading that ankle has seen over years, and that bone is soft. So beware of the plantar valgus ankle and the medial malleolus, and then recognize and fix intra. And sometimes that's not the most straightforward thing. This case here is a case of mine. You can see this is the picture on the left is my 6-week post-op x-ray. I am at that point realizing that I did have a medial malleolus fracture that was not critical enough of during surgery. And I had guarded this with the K-wire during the surgery, but in putting the implant in is when this would have happened. So I took this patient back 6 weeks post-op, and she healed uneventfully, besides that little return to the OR we never want to do. Alignment correction. So I don't go into a lot of detail here, but we know and we understand that these ankles are designed to function and last in neutral alignment. So if we have a cavus plantar valgus foot or other deformity, getting that alignment close as neutral is important. Do we do that as a stage? Do we do a concurrent? I think you have to weigh all the factors there. Staged, having 2 surgeries to most patients is probably not appealing. I've had some patients that I've really thought I wanted to do this, but it was hard to talk them into, and I talked myself out of the stage procedure. Concurrent is what I do most of them. You've got longer operative time, which we know from the previous study has increased risks of wound healing. But it is I typically make in getting a more new alignment under our total ankle. Gutter impingement. This is another technical matter. It comes down to as simple a thing as put in the implant that fits, and it's not too big. The problem that I had here in this patient is she was Asian descent. She's 4'9", maybe 4'10". I sized the implant and I knew it was small. This is the smallest option I had with the system I'm using here. I thought I made it fit. I was being very optimistic. She had pain after, and the CT scan there on the right really shows she's impinged not only on the tibial component, but also both sides of the talus. So I never wanted to have this revised yet. And I don't know of it. I look at I don't know of other ones that would fit her. If anybody out there has an idea, please let me know. And then infection. This is one that obviously is a scarier one. Is one of the complications that can cause the true failure of the. This was a infection that was actually dealt with at an outside facility and was explanted there. This cement spacer was placed there. The patient was not particularly able. She had been lost to follow-up at her previous institution. I elected to do the only time I've ever done this is a shortening fusion. I shortened the height of the spacer and then put this frame on her. She proved herself to be unreliable, and I did not see her again for 7 months. I was lost to follow-up despite trying to contact her. She came beautiful pin sites, had fused, completely fused her ankle, and I have not seen her somewhat shorter ankle. More standard for my practice whenever I had, and this is a case of mine, total ankle that got this spacer in. 6 weeks later, I took that out, used a femoral head allograft to do an ankle fusion. In the case of my partners, much more involved osteomyelitis of the distal tibia from a larger implant. He took the previous spacer out, larger spacer in, replaced the distal tibia with PMMA and with antibiotics. And then after a period of letting that wash out with IV antibiotics, put in this 3D printed cage through which he placed a TTC nail for fusion and with bone graft in it. So away from infections, this is another case from Dr. Diorio. He did this case with a star ankle in 2012. That was the year I was at Iowa, and I did this study with my mentors there, looking at the blood supply of the talus. And it was a barium injection CT scan study looking at 4 different implants. And then we walled these cadavers with bleach. And we looked at the proximity of the different cuts and drill holes that are used with these different implants to the blood supply. This is an example of the in-bone artery of the tarsal canal and the proximity to that. This is that medial talar saw used on the star implant. You can see kind of the DOC of that, the posterior medial deltoid supply of the talar body. This is a chart that is in that manuscript that looked at a color-coded warning sign like a hurricane or weather alert as far as the danger to the blood supply from the different implants. So this is Dr. Diorio's case again. 2012, the patient's doing just fine. We start to see the slow collapse over the next 8 years. Full subsidence very well could be AVN. He got a CT scan that suggested as much, and he revised this with a total tail, which is another option I'm sure we'll hear about in further sessions. Brief review of the literature. This is a study that we're familiar with, Glazebrook, looking at meta-analysis of 20 different studies. Subsidence and aseptic loosening being the most common, deep infection being the least common. However, it was likely of the high-grade complications here to cause failure and loss of the implant, along with aseptic loosening being second. Another look at the literature with the complication rates. If you do more volume, you have less complications. And the number in this study, which is a database study, was more than 20 cases per year. Some other decreasing patient trends: low complication rate for outpatient total ankles, very similar to inpatient. Similar to what I was talking about with alignment correction, this study suggested that the second study there, additional procedures do not increase complications. Balance that with the surgery time, of course. And then this JVGS study at the bottom showed the increased utilization and decreased complication rate of total ankles compared to ankle arthrodesis over a 15-year period. These next few studies look at patient selection issues. Obesity, you have a database study that shows an increased risk for all complications from over 5,000 total ankles with obese patients. But then a prospective study from Duke looking at their large series of patients with no effect of obesity and complications. Similarly, you have diabetes, 2 database studies showing increased risks with diabetes, but then Duke with their case control group of 100 total patients with non-neuropathic diabetics showing no change. And then age, this was a paper last year from Duke that showed less than 55-year-olds had greater rates of complications and greater and lower functional outcomes. So last slide here. So as we know that total ankles are safe, improving with their design, there are still things that we have to be aware of. Looking out for, as we think about our implant designs, where we're making our cuts, the tailless blood supply, and also thinking about the patient's history as related to that. Thinking about operative time and efficiency and what we're choosing to do during that same case. Patient selection, whether that's vascular status, checking neuropathy, thinking about obesity or diabetes, those are all very important. Technical guarding and fixing the malleoli, and then also don't put implant in that's too big. Thank you.
All right, Josh, thanks a lot. You have to keep in mind, right, these complications are real, and they can keep you up at night, and you have to be ready to deal with them when you do total ankles. And the more you do, I think the better we are, but they're never easy. Just a couple thoughts here. We have a few minutes. I wanted to go back to Rishan here. You mentioned some of the future technologies that we may have. What do you think is going to be the next step for total ankle? And how about, you mentioned it briefly at the end, but how about navigation robotics? You have a sense of if that's going to be reality?
I think navigation is probably the next big ticket. The challenge with navigation is consistent landmarks. Ankle arthritis, unlike hip and knee, as post-traumatic, so everyone's anatomy is so different. There's just every varus ankle is different, every valgus ankle is different, so the deformity and the inconsistency in anatomy makes it tough. But I think that's probably the next big thing, I would think. I know there's some companies that are working to develop that right now.
In a similar line, do you think we're going to get to the point where everybody's getting a custom implant?
Until the cost of 3D printing goes down and the time to print, I don't think so. I think the cost of custom 3D printed taluses, cages, that we'll see are pretty expensive. So the indication has to be met to warrant that kind of cost. And we have some pretty good implants that have been developed recently that, we just have 5-year data on just because they've been out for 5 years, so.
Yeah, I'm with you. Although you think about we're 3D printing the PSI, I mean, that's a different story because that's just a small amount of surgical nylon, but it seems like the capability will be there, but you're right, it's probably a matter of cost. Josh, back to you. You mentioned this staging. It's a question I always ask myself, and I get nervous when I have a whole lot to do because I only want to be in the operating room for a certain amount of time. Well, I'd be there as long as it takes to make a case go well, but I know that there's limits. So what kind of things are you staging versus not, and what do you feel comfortable with?
Well, I mean, I will do kind of a basic foot cable varus or plantar valgus foot reconstruction. And I'm willing to do, I don't really have a time. I don't really have a number of procedures necessarily. I guess I have a sense of how efficiently I can operate. I think we've all got to make that decision for ourselves. I think for me, a typical plantar valgus foot reconstruction is probably in the range of 90 minutes, something like that. So if I need to add that to my total ankle, I can do that. So pretty similar for a cable varus foot. If it's a lot of osteotomies, if it's a distal tibial, I mean, I can't imagine doing a distal tibial osteotomy, but if it's really getting involved, or if your own practice is taking you, longer than, a longer amount of time than you want to spend in the OR, I think that's an individual surgeon question. So that's probably why I tend to gravitate toward doing it all together, but I'm not saying that's right. And I think that's just my own practice. So.
Rishan or Casey, any other comments about that? But when you stage?
I am, it just, again, I agree with, Josh, it really depends. Some of it is case by case. The only thing I am very hesitant to, or I'm very quick to stage is if I have to do a subtalar fusion. I worry about, damage or insult to the talar blood supply. So if I ever have to do a subtalar fusion, whether that's for a pes plana valgus or for whatever reason, I will stage that. So I'll do the procedures with the subtalar fusion first, and then come back and do the total.
I couldn't agree more with that comment. I'll do osteotomies, if I need to realign, especially with varus, I'll do some ligament reconstruction, but I think you really have to let that subtalar fusion heal, because if you try and do that and you happen to kill the talus, you're going to have a much, much worse problem. So I completely agree with Dr. Kadakia.
Yeah, and I do too. Okay, thank you so much, guys. Casey, Rich, and Josh, great job. Seelan, again, congratulations and good luck. We're going to end there, give a minute or so here for the next group to come on. And,
thank you, everybody. Fantastic session. Thank you for kicking us off in a very high level. Appreciate all the expertise, guys.